Patients who present with CGD, especially the boys who have the X-linked CGD, often present early. And by early, I can mean as early as infancy. They can present with severe infections or unusual infections. Severe infections can be internal organs that develop a bacterial infection or a fungal infection. These can be in the liver, in the spleen, in the kidneys, in the blood, and even in the brain, like a meningitis. So some of these infections are quite serious. The children need hospitalization, IV antibiotics, surgeries to remove the infected tissues. It can be quite life-threatening right from a young age onwards. The reason it presents so early and so intensely in those boys is because they only have one copy of an X chromosome, and the copy that they have of that X chromosome bears the broken gene. They have no backup plan. So all of their cells, all of their white blood cells, lack the ability to kill certain kinds of bacterial infections. So pediatricians should be alert for any patients who have severe disease, severe infection, what we call opportunistic infections, which are unusual infections with organisms that don't normally occur in healthy children. These include fungi and unusual bacteria.
CGD can present in a variety of ways. The most common way that we pick it up or start to think about CGD is a young child that has an invasive infection that's usually due to one of the organisms that we know are commonly seen in children and adults with CGD. So there are a series of germs that we know folks with CGD are very predisposed to infections with. And the main ones are the bacteria Staph aureus, Staphylococcus aureus, and then there's a mold called Aspergillus, and a few other bacteria called Nocardia or Serratia, and then Burkholderia. And that list, those 5 organisms actually cause the vast majority of CGD-related infections in the United States.
I go back to the example of Burkholderia cepacia. If an immunocompetent patient showed up with a low-grade fever and flu-like symptoms, I would probably say go home and drink lots of water and drink chicken soup. If a patient with CGD showed up with those identical symptoms, I would tell them you have to go to the emergency room, get a blood culture. I'm worried that you might have a Burkholderia cepacia bloodstream infection that could kill you very quickly.
So traditionally, we thought that the female carriers of X-linked CGD were relatively asymptomatic. It's true that an X-linked affected boy could have developed his disease from a de novo mutation, but usually the trait is inherited from his mom. There's much growing evidence to show that these female carriers are quite symptomatic. And recent work from the NIH showed that when their enzyme activity, their oxidative burst drops below 20%, they are at increased risk for developing the same kinds of infectious complications that the X-linked CGD boys can develop. What's also been shown, however, by multiple groups throughout the world is that these X-linked carrier females can start developing autoimmune disease even when the amount of the respiratory burst is still above 20%. Why this is, we don't know, but we do know that the respiratory burst, which is related to inflammation and protection from free radicals, it's no big surprise then that when something goes awry in this system, that autoimmune complications occur.
Other unrecognized complications of CGD are the autoimmune complications. So these patients can present with vasculitis and granulomas almost anywhere in the body in terms of a Crohn's-like colitis, pyloric stenosis from granulomas in the pylorus, granulomas in the vocal cords, in the sinuses, in the lungs, in the bones. So the inflammatory complications related to CGD often go unrecognized and misdiagnosed as other granulomatous or autoimmune syndromes. But especially in the United States, since 70% of the patients have X-linked CGD and are boys, any patient, especially boys, that present with severe autoimmune complications should be screened for chronic granulomatous disease. So although this is a rare disease, right now I think the statistics are about 1 in 250,000 in the United States. It's not rare for the patients, and it's not rare for the patient's family. It's what they live with. So it's important to keep CGD on the differential for any of these inflammatory or infectious complications, because the earlier that it's diagnosed and the earlier that therapeutic interventions can be implemented, the better the outcome for the patient. And early diagnosis, early intervention, and treatment and resolution of infection and autoimmune complications are very key to the referral for bone marrow transplant, because these patients' outcomes are better if they come to transplant healthy without severe infection or autoimmune complications. And their lifelong survival is better if all of these are under control, taken care of, and diagnosed early.